Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh, and a very good morning to all our audience in this virtual room. Today's clinico-pathological conference is brought to you by the Department of Psychiatry. And for today's topic, the team of presenters will be presenting an interesting condition, a condition that is very rare, occurring in 1 to 18,000 to 1 to 40,000 male population. So it's going to be an interesting condition to learn. So stay tuned, everybody. Before we start, I would like to introduce to you the presenters today. First presenter will be Dr. Nur Atikah Razali. Dr. Nur Atikah is in our Doctor in Psychiatry training program. She's in second year at the moment, based in Hospital Bahagia. And second presenter is Associate Professor Dr. Nur Azimah Muhammad. Dr. Nur Azimah is actually our head of department of family medicine department, and she's a senior consultant family medicine specialist with interest area in adolescent and youth. And our third presenter is Dr. Tuti Iriani Muhammad Daud. Dr. Tuti is our senior consultant psychiatrist in the department. And so how the session will flow is that it will start with presentation of case by Dr. Nur Atikah. Then followed by an introduction to this syndrome by Dr. Tuti. And then Prof. Azimah will be talking about the management of this condition in the primary healthcare setting. Then will be completed by Dr. Tuti again to talk about the psychiatric aspect of this condition. So without further ado, I would like to invite Dr. Atikah to present the case.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to our chairperson for today, Prof. Mahani, other presenters, Dr. Tuti Iriani and Prof. Nur Azimah and other participants. Today we would like to present a case of bipolar mood disorder in a young man with 48 XXYY syndrome. So I proceed with the case presentation. A 21 years old Malay man with underlying 48 XXYY syndrome, attention deficit hyperactive disorder ADHD, and intellectual disability was admitted to the psychiatric ward for being aggressive at home. So some background history of the patient. The patient was first found to be a floppy baby and detected for having cerebral atrophy after a CT scan at the age of 7 months old. He was then referred to pediatric neurologist. A number of tests, including a chromosome test and a MRI, was done at 11 months old, and he was found to have 48 XXYY syndrome. His diagnosis was followed by a series of physiotherapy and later speech therapy. He started walking at the age of 2 years old and had speech at 4 years old. His behavioral issues started about at school age. He attended a special class which focused on a skill training since he was 7 years old. He was diagnosed with attention deficit hyperactive disorder, ADHD, and intellectual disability at the age of 9 years old. His behavioral issue became more significant when he became a teenager. He started to smoke at the age of 13 years old. He became impulsive, easily irritable, physically aggressive, and often through tantrum behavior. He would be uncontrolled if his needs were not approved, such as when he demanded for money, smoking, and going out of the house. He was seen by a child and adolescent psychiatrist at the age of 13 years old and later to the pediatric endocrinologist. He was given an injection to stop hormones in attempt to control his aggressive tendencies, but was stopped after 6 months after the treating doctor felt that the injection was not helping and concerned about the future impact on the bone. At 16 years old, he inappropriately became romantically and physically attracted to girls and tended to hit another person. He was started on sodium valproate to control his aggression. He came to our attention at the age of 19 years old for continuation of treatment, despite on triple medication, which were a sodium valproate 400 mg on morning, 600 mg at night, tablet haloperidol 2.5 mg at night, tablet risperidone 2 mg twice a day. He was still reported to be aggressive. Okay, then 2 years later, his impulsivity worsened, which at times required him to be restrained by his family members. He demanded for expensive items and there was increase in sexual drive. He would punch his father and brother if his demand was not met. He was admitted to the psychiatric ward for being aggressive at home. Further assessment revealed that he was experiencing other manic symptoms such as talkative, a reduced need of sleep, high energy, and having many plans. He had a strong family history of bipolar mood disorder, whereby his maternal grandmother and auntie were diagnosed with the condition. His mother identified his behavior to be similar to his grandmother. Of clinical examination revealed a tall young man with height of 1.8 meter, weight of 106 kilogram, making the body mass index BMI of 32.71. His blood pressure was 143/75 millimeter mercury, pulse rate of 92 beats per minute. He had a long face with bitemporal narrowing, prominent brow and also chin. Other system examinations were unremarkable. Mental state examination revealed a tall young man appeared hostile with superficial rapport and having a good eye contact. He was talkative with coherent and also relevant speech. He also had expansive mood with appropriate and also labile affect. He had flight of ideas. There was no delusion, suicidal ideation, or abnormal possession of thought. He also had no perceptual disturbances. Blood investigation showed that he had a deranged fasting lipid profiles with total cholesterol was 5.66, triglyceride was 3.1, and high density lipoprotein HDL was 0.92. His blood sugar was normal, with HbA1c 5.3% and fasting blood sugar of 4.88. Other investigations were normal. The patient started to have impulsive behavior since he was 14 years old. When he was 21 years old, his impulsivity was worsening apart from sexual disinhibition and also spending spree. There are few factors which are correlate and with the challenging behavior in adults with intellectual disability. First, in psychosocial vulnerabilities such as negative life event, impoverished social network, lack of communication skills, and also lack of meaningful activities and also psychiatric or mood problem. Second is the biological vulnerability, factors such as health, sensory, and also genetic factors. So for this patient, the symptoms initially attributed to his challenging behavior related to ADHD and also intellectual disability. Hence, the sodium valproate was initially increased. However, it was inadequate to control his aggression and many symptoms that led to the hospital admission. In view of his presentations and a strong family history of mood disorder, the diagnosis of bipolar 1 disorder was established. So for the treatment, as mentioned earlier, this patient was on a number of medications, including antipsychotics, to control his aggressions and also impulsivity. He was started on tablet lithium 300 mg twice a day, and also intramuscular paliperidone 150 mg monthly during the admission and discharge after 8 days of inpatient treatment. During and also follow-up. During his follow-up, the manic symptom has improved. There was still some spending spree. He was referred to quit smoking clinic for nicotine replacement therapy and had successfully stopped smoking. His latest medication were tablet lithium 300 mg in morning and 600 mg at night, sodium valproate 600 mg twice a day, risperidone 2 mg twice a day, intramuscular injection of paliperidone 150 mg monthly and also olanzapine 10 mg PRN basis. In addition, he was referred to a dietitian and also a family physician for his metabolic conditions. A latest update of the patients revealed that he still has some spending spree whereby he purchased for 7 fishing rods at one time through online and ordered a lot of food for the whole family and they had no cash at that time to pay for the delivery food. Recently, he also experienced a bedwetting or nocturnal enuresis for 3 times a week compared to his previous history of bedwetting at the age of around 13 years old at that time. He had bedwetting around twice a month only. So this made his family having some difficulties, especially during travel, as they needed to bring a sleeping bag for the patient. Okay, so that's for clinical presentation of the patient. Thank you.
Thank you, Dr. Nur Atika. So we will proceed to Dr. Tuti now. Dr. Tuti need to unmute your speaker.
Okay. Okay. Can you hear me now? Can you hear me?
Yes, loud and clear.
Assalamualaikum and good morning, everyone. I'll start with a bit of introduction regarding the XXYY syndrome. When I first was referred regarding this patient, I was very apprehensive and overwhelmed. I've never heard of this before, and I think I've always had this apprehension when dealing with adults with intellectual disability in view of I didn't have much knowledge about it and I would like to learn. But this patient came to us and this started our journey of trying to understand what is XXYY syndrome. Okay, so XXYY syndrome is a sex chromosome aneuploidy, okay, and these are the types of sex chromosome aneuploidy that exist. And you can see from not having enough 45XO is a Turner syndrome, okay, so that's not having enough chromosomes and having extra chromosomes. And with sex chromosome aneuploidy, the extra chromosome is the sex chromosomes. So the most common would be the Klinefelter, which is 1 in 450. And XXYY syndrome is around 1 in 18,000 to 40,000 male births, as mentioned by Prof. Mahani just now. Okay, so what does that mean? That means, well, this is based on 2015 data. So worldwide, it should be 212,000. But in the United States alone, I think from their registry, there's only a few hundreds at this moment. So they're getting, they have this registry and they're getting more and more individuals with XXYY syndrome in the database now. But for Malaysia, if we, based on the 1 in 18,000 incidents, we should have 539 for the year 2020. So for now, in the registry, from the registry, there's only 1 from Malaysia. So we need to look out for another 500. And I guess this is one of the purpose of this presentation. So I would like to take this opportunity to mention about the Rare Disease Day, which was on the 28th of February. So Rare Disease Day is a rare disease, meaning that less than 1 in 2,000. So definitely XXYY syndrome is considered one of the rare diseases, and they're advocating for social inclusion and universal health coverage. I guess this is for the United States. Okay, so what are the hallmarks of XXYY syndrome? Please excuse me if I'm not explaining myself very well. I'm still learning about XXYY, and there's a lot of new terms that I'm learning. So if I'm not doing justice about regarding this aspect, please forgive me. So this is a hallmark of XXYY syndrome. It's low muscle tone, speech delay, developmental delay, and hypogonadism. And they're extremely tall. So for our patient, he was 1.8 meters tall. Okay, so what I wanted to do initially was to show the pictures of those photos of those with XXYY syndrome, but to respect the parents and the patients themselves, and the pamphlet said that we are not allowed to reproduce the photos, but you can you can Google on this pamphlet that mentions about and how to identify XXYY syndrome. So there's a lot of photos over there in that pamphlet. And yes, I can see how they can be misdiagnosed. So, I mean, they're not misdiagnosed, they're just not diagnosed and had karyotype has not been done. So one of the features in terms of facial features are wide set eyes, large bridge of the nose, full lips, folds in the eyelids, large foreheads, prominent brows, and sometimes pronounced indentations in the temples. Okay, so that is in terms of the facial features. There's more information in this pamphlet. Okay, so I initially communicated with Prof. Azima saying that, we would like to refer this patient for metabolic syndrome, because we know that our medications are notorious for causing metabolic syndrome. But actually, Prof. Azima, the reason we're referring to you is for this whole thing, actually. The other associated diagnosis that occurs with metabolic syndrome. So yeah, I think we really need help because we don't think we can monitor this alone. Because when I asked the parents, are there any, are they going for follow-up with other doctors? At this moment, it was just us. So I needed help. And one of the things, as you notice here, is non-Hodgkin's lymphoma. Lymphoma is one of it that we have to look out for. And also deep vein thrombosis. Okay, so I pass over to you, Prof. Azima.
Right, can you see my slide? Can? Boleh? Assalamualaikum warahmatullahi wabarakatuh. Can you hear me? Boleh dengar saya? Alright, okay. Thank you so much, Department of Psychiatry, for inviting me to present, to sort of involve in this CPC. Yep, as Dr. Tuti mentioned, she was apprehensive, equally myself, because this is perhaps the first and maybe the last case that I would see in my entire profession. But anyway, I would like to share what had actually happened, or what sort of things that we do when we see this patient at our center. Right. So the first time that I saw this young gentleman, a 21-year-old young man with 48 XXY syndrome, was on the 30th of November 2022. And at that point in time, I just cut short. It was rather easy for me to develop rapport with him. He was quite forthcoming. He was mentally stable with no delusional thoughts or obvious manic or depressive features.
Can I just are you showing your slides in the slideshow?
Yes, you cannot see, is it?
We can, but we can also see your notes.
All right, okay. Hang on there. Okay. Now I'm lost. Hang on.
Cikgu Hari, can you please help?
All right. Where are we?
You try to share screen again?
Yeah, but I just looking for you. Ada sekejap ya. Okay. Right. Okay. Now you can see this?
That's right. Yeah. Now it's in the correct form.
All right. Okay. Sorry about that. Okay. So when I saw him on the 30th of November, it was rather easy for me to establish a rapport with him. And clinical evaluation, as Dr. Atika mentioned, he was definitely in obese range with the BMI of 32.71. Physically, you can't really appreciate any obvious abnormality. He looks like any other normal young man. Yeah. So for the CVD risk assessment that we did at that point in time, the total cholesterol review of the previous blood investigation, as Dr. Atika mentioned, the latest was perhaps 5.6, but there was one time it went up to 6.41 with the LDL of 4.55. And the HDL was 0.9. The blood pressure that I actually recorded at that point was 124/86. It was normal, yeah. And the fasting blood sugar was 4.8. He sort of did not have any family history or sudden heart attack. Yeah? And he used to be a smoker, but stopped smoking over the last 1 year. Yeah. So, well, you can't really use the Framingham score to sort of risk stratify him, but based on whatever the risk factor, because of the age, he's 21 years old, but looking at the overall risk assessment, definitely perhaps the risk for him to have MI or death over the next 10 years perhaps is still rather low, perhaps less than 5%. In terms of the medication, yes, as Dr. Tuti mentioned, all the antipsychotics are known to cause weight gain and diabetogenic. Yeah? And using the HITS risk assessment, looking into his home, education, eating, exercise, activity, drugs, sexuality, suicide, and safety, his diet, he is actually in very high calorie diet. Estimated total calorie per day perhaps is around 3,000 kilocalorie. And his highest dietary intake would be during dinner time, where he actually joined his family members to have dinner, a dinner 4 times. Yeah? It begins at 6:30 when he joined his parents, then he'll join again his brother at 7:30, followed with his sister, and later the maid. Yeah. So, and in terms of his exercise or activity level, he definitely in the category of practicing a sedentary lifestyle. He goes to Wisma Harapan, for vocational training, and definitely very occasionally he actually play bowling. Okay, so that is what happened to him. So and based on our assessment at that time, these are the list of our problem. He has obesity, no doubt, dyslipidemia, with the premorbid bipolar disorder at that time was stable, ADHD, intellectual disability, but positively he has supportive family, and he actually had early intervention program and currently in Wisma Harapan for vocational training. So what are the challenges that I sort of anticipate in managing this young man is because of his intellectual capacity and mental status, is quite difficult for us to actually recommend lifestyle changes, although no doubt based on literatures, by actually reducing the body weight perhaps in him by 10% would actually reduce the sort of cardiovascular risk factors in many ways. Yeah, but definitely it would be really a challenge for us to sort of advocate the lifestyle changes, namely include the physical activity as well as the dietary modification. He was, yes, referred to a dietitian for a proper dietary counseling, but that need the family commitment, as well as just like to share, he actually has a personal assistant who actually accompany him to the school and will be with him up to about 6 p.m. So this sort of a brother, he called brother, yeah, abang ini, who perhaps need to be in the treatment picture as well for any lifestyle changes that we would like to advocate in him. And another problem that I think that we need to look into, because he's rather smart and he can actually order food himself. And as Dr. Atika mentioned, he actually, because of his illness as well, there were times that he sort of over ordering of the food to the home. Yeah. And definitely, to sort of self-discipline him need a lot of commitment from the family. So that is in terms of managing his obesity and dyslipidemia. For the bipolar, I'm sure our psychiatric colleagues are doing their best. And what we will do at primary care, just to sort of monitor the treatment compliance, monitor for side effect, that lithium, for example, we know that it can cause hypo or hyperthyroidism, as well as electrolyte changes up to cardiac arrhythmia. So that perhaps would be our part in terms of helping our psychiatric colleague. And definitely we would sort of be the feeder in sort of sharing whatever that we think perhaps need some adjustment in terms of his hypomanic symptoms. Social issues, yes, as Dr. Atika mentioned, he was sort of at 16 years old, he started to have this sexual desire. When I saw him on the 30th November, I didn't really had a chance to really explore in depth in terms of sexual relationship, but he admitted of having a special girlfriend whom he actually accounted for quite some time. But this is something that we need to explore, looking into the overall picture of this young gentleman. So what is our long-term plan? Yes, definitely. We would need to still advocate weight reduction in him, and we need to try at our very best to do that. Yeah, and we need to monitor his lipid profiles, the sugar levels, the thyroid function test, electrolytes, and as Dr. Tuti correctly mentioned, there are a lot of other potential complications that he may have that include lymphoma and the DVT that we need sort of to monitor at our every visit. And because of his obesity and dyslipidemia, and it's quite hard for us to actually just purely concentrate on the lifestyle changes, although perhaps his risk for cardiovascular is rather low. There's still, I think, a value for pharmacological treatment in terms of preventing him to develop diabetes in view of the condition itself has been documented, has an association with type 2 diabetes. On top of that, he also on medications that are diabetogenic. Yeah, so perhaps there's a value of metformin in him, but we would sort of monitor and at this stage, I may actually need to consult our endocrinology colleague as well as our cardiologist whenever there is a need in terms of this pharmacological management. Yeah, and the two medication that we may want to consider in him is definitely the metformin, yeah, based on the DPP trial and the statin. And the long-term plan for his mental well-being, yes, of course, he has to continue the psychological and behavioral intervention prescribed by the psychiatrist and ensure his treatment compliance, and we would alert our colleague if there's any psychiatric flare-up. And to continue the supportive family and continue his function in a society, hopefully one day he'll be independent, yeah, and ensure he's practicing safe relationship as well as sexual practices, and ideally perhaps he would actually remain sexual abstinence. And we need to actually monitor other risky behaviors, and we hope he would not go back to his smoking behavior as what he had happened before due to the peer pressure. So with that, I thank you.
Right, thank you, Prof. Azima, for highlighting the role of a family medicine health specialist in the care of this patient. We'll go ahead with to present the psychiatric aspect of the condition.
Okay, so you can hear me and you can see my slides?
Yes, Dr. Tuti.
Okay. Okay, so I'm going to talk about the psychiatric aspects of the XXYY syndrome. Sorry, yeah. Okay, so the first thing is that we want to discuss here is behavioral problems in individuals with intellectual disability. If we look at the timeline that was presented by Dr. Atika, he started to smoke at the age of 13. Well, because I would like to explain here how it started. It was like I think there was there were some contract workers in the neighborhood because they were building a house. So because he's friendly, he goes out and he talks with everyone. And there were instances that he would sort of disappear. And the family, had to inform the police that he has disappeared. So he would, there were instances, there were several occasions that he disappeared. So he would, during those times, he would mix around with whoever is around, okay? And that's when he was introduced to smoking. There were situations where there were many instances where his behavioral problems were related to smoking. Of course, the family didn't want him to smoke. They tried to limit smoking as much as they can, but when he demanded it and he didn't get it, then he would become at times aggressive and hit the family members. So we sort of focused on that. We thought all this aggressiveness was, okay, this is about nicotine use disorder. And we, of course, because he has intellectual disability, it's understandable that this happened. But looking back at his, he was on and off aggressive from the age of 13 to 20, but it became worse, and it didn't sort of, it was not in relation to smoking anymore. And in between, there was this sexual disinhibition that occurred. So looking back, is it nicotine use? Is it part of the, growing up? But maybe we should have considered other things earlier. So looking at the neurodevelopmental diagnosis based on a paper in 2008. So for XXYY syndrome, this 91% would be speech delay. There's, in terms of ADHD, is up to 70%. Learning disability and motor delays is also 70%. If you look at the previous psychiatric diagnosis, in terms would be oppositional defiant disorder. So Dr. Tartaglia from Colorado, Denver University, in her paper, she mentioned that about 50% mood disorder was about 50%, but the categories are it's generalized anxiety and OCD is included in that. So for us, we would consider just the depression, bipolar disorder, and cyclothymia as mood disorder. So we would say a quarter would be mood disorder rather than about 50%. So around 8% was diagnosed. In her sample of, it was about 96 individuals. This is out of 96 individuals with XXYY. And Tourette syndrome was in about 20%. So looking back again for our patient, maybe the diagnosis of bipolar should have been considered earlier. We diagnosed him last year, 2020, when he's about 21 years old. But should it be considered earlier on? First, there's maybe 1/4 of people with XXYY had mood disorder. Number 2, bipolar in individuals diagnosed with ADHD is higher. There's a higher rate of bipolar in individuals diagnosed with ADHD. And in terms of hereditability for bipolar disorder, it's 60%. So he has 2 second-degree relatives that was diagnosed with bipolar disorder. That was a grandmother and an auntie. So somehow, because of the XXYY syndrome, this part of the history was, we probably forgot about it. because of we were just too scared of the XXYY syndrome. What else? What should we find out? What should we do? We just forgot this aspect. And I was just wondering, looking back and learning from this, that we could have diagnosed this earlier on. And in that sense, we could have prevented instances where the family had to pin down the patients when he was aggressive. So this is one of the important things that we wanted to share with you. So because of the metabolic syndrome associated with epilim, so we try our best to choose a medication that is less associated with metabolic syndrome. But of course, lithium does cause weight gain, but it's not as much as other atypical antipsychotics. So we started him on lithium. I mean, anyway, epilim was not working. And we noticed when we started on lithium, he improved. I'm hoping the reason we used intramuscular paliperidone was we wanted to sort of bypass the first pass effect. So maybe it's more effective when it's intramuscular. And we are hoping that we can reduce the atypical antipsychotics. However, based on our conversation with Mom yesterday, the fact that he shot for 7 sets of fishing rods, and this he is smart enough to download an app on his own and shopped. It was not Lazada. Mom said it was not Lazada. It was not Shopee, but out of the blue, somebody would come and deliver something to the house. And every time the parents had to sort of negotiate, instead of buying 7, maybe they bought 1. And, suddenly they would, pizza would come. And so it is unpredictable whatever would come in front of the door, whatever would appear in front of the door. So this is what the family has to endure. And for me, I wanted to reduce. I'm thinking of reducing all the medications based on the concern about metabolic syndrome, but I'm not sure whether I can do that at this moment. So the third thing is about smoking, okay? And we know smoking, the prevalence of smoking among individuals with mental illness is higher than the rest of the population. So for him, he has stopped smoking. That's a great relief. But for the purpose of this case presentation, this is something that we need to discuss as well, because it is true that the smoking is increased in patients with mental illness. In patients with intellectual disability, smoking is about 20%, okay? And in patients in individuals with XXYY syndrome, the risk of DVT is 18%. We do not know why. Based on the mechanism is not known why, but all this information makes us concerned that he might have a DVT or he might develop a pulmonary embolism because of that. But I'm glad that he has stopped smoking. Because we're talking about smoking now, I would like to mention that in 2020, WHO released this paper on tobacco use and mental health conditions. And what they are advocating is that, the effort to reduce smoking worldwide there was some success. However, we need to work more on people with mental illness. It seems that the rate of smoking in people with mental illness is not reduced. And this brief is dedicated to psychiatrists and primary care physicians. Prof. Azimah, we know you can do your magic, and all the magic, not just one magic. This brief is actually for us mental health professionals to help with the smoking cessations among our patients. Okay, so I'm about to end here. So I would like to share with you the XXYY project. It is an advocacy in the United States and Canada, where they are trying to find patients, and so they can get more numbers and they can do more research on XXYY syndrome. You can follow them on Twitter, Facebook, of course, and the website. So if you think, as I shared with our patient's mom yesterday, one of the objective of this presentation is maybe someone out there might be thinking that, hey, maybe my son or my relative or a friend of mine has XXYY, and maybe they should get tested. So this is where if you do think of someone, maybe you can advise for genetic testing, or they can consult their primary care physicians, like Prof. Azimah, and if they do have XXYY or other sex aneuploidy, they can contact the AXYS helpline. Okay, so on a personal note, if this happens to you, in a sense where you are you get a patient with a rare syndrome, there might be go straight to the internet and go straight to the support group. Maybe the articles might be overwhelming for a start, but there are some support group out there which has simple information for you as a start. Don't work alone. You work as a team, and of course we have our family physicians to perform the magic. Thank you. I think that's all for me. So I guess this to you. I pass over to you, Prof. Mahani.
All right. Thank you very much, Dr. Tuti. Looks like we have quite a bit of time for Q&A or for further discussion. I don't see any questions in the chat box. Anybody would like to have a question to the panel of speakers? All right, okay. If there is no question, since we do have time, any of the presenters, do you want to add anything else to the discussion?
Ada Kahoot, Prof.
Kahoot, I see. All right, so we proceed with Kahoot. Right.
Okay, thank you.
All right, okay. So we can proceed, Cik Buhari.
Yan, Tuti, do you want to answer the question?
What question?
In the chat, what other things we can help to manage the behavior problem apart from pharmacotherapy?
Oh, okay. I think we're thinking. Probably we need to have a family session and see, as Prof. Azima mentioned, that I think the caregiver needs to be involved as well, and maybe we should have a family meeting and see how we can. Because now it's he goes to your appointment and then he comes to my appointment. So the next would be a family meeting and see where we can go from here. Because I think it is hard in terms of the, suddenly something appears at the door. I find that, that's hard. And I think we need to assist in that. And but however, we need to understand the condition as well. Because he is smart. Can you stop him from downloading apps? How do you do that? So we have to be creative as well. So in other words, we need to understand the circumstances in the household. I would imagine, I mean, when you have gadgets all over, you need gadgets.
Yeah.
You stop doing that.
Just to add, I think one of the things that perhaps we need to look into is in terms of making sure there's a boundary in whatever his activities, which is, yes, definitely rather hard because of his premorbid condition. And there's a need parents to sort of improve the parenting from being too permissive to more authoritative style. Although he has that intellectual disability, but I still think you sort of can help him to understand the consequences of his behavior. Just to share, I saw him last Monday, and he can actually remember what the advices and the food that I asked him to avoid. So that is sort of an achievement to me when he actually recognized what are the food that he need to avoid, although he has yet to practice that. So in essence, I think family therapy is definitely very, very important in this case. And perhaps we can sort of make that family therapy, and I'll be in the treatment as well. So instead of we put it or we manage it separately, so that we can see the whole context of this patient.
Yeah, and we can do that virtually.
Yeah.
We can do that virtually. Yeah.
Right. That's an important aspect of management of this patient. Yeah. About the behavioral problems. Do you think that the behavioral problems are part of the bipolar, or do you think it's part of
ADHD?
ADHD, or is he trying to to just be like other young people, trying to exercise his intelligence?
Right. Yeah. Tuti, do you want to answer that?
It's difficult. I mean, I'm taking time to answer that. I personally think it's difficult to answer, but when we started medications for bipolar, when we decided, okay, the diagnosis is bipolar, and we started medications for bipolar disorder, I mean, things has improved. He doesn't need, he's not that aggressive anymore. Even his, he had pressure of speech before. So it's less now. I mean, he doesn't talk all the time. However, this bit about shopping and the shopping it's still there. Maybe I can say it's a bit of both. It's a bit of both. But when you have bipolar and ADHD, maybe it is taking time to improve. Yeah. So, frankly speaking, I do have problems answering that question. Yeah.
Right. It can be challenging. Yeah. Just now, Pro Azima was saying that at least he could remember the content of the discussion from the previous session. Sounds to me there is some receptiveness of from him to do something about it. So probably along that line, behavioral measures or involving the family may actually work. We don't know, but we can try.
Yeah.
Right. So the quiz is still ongoing. Yeah.
Kita sedang on Kahoot.
Perlu buat apa Cik Buhari? It looks like there is one question from the Q&A box.
Kahoot dan
Tak berapa dengar Cik Buhari? Somebody has to help me to interpret this Kahoot scoring.
I think Kahoot is for students, and I think there's another one or two. Yeah.
Ada participant raise hand. Ada participant raise hand, I don't know how.
Ada participant raise hand?
Yeah, but well, I don't know. Macam Cik Buhari?
Kita tunggu Kahootnya.
Alright, okay, yeah.
Okay. So saya akan share untuk CPD. So gunakan apps NMA.
Okay, are we closing the session now Cik Buhari?
Boleh Prof, sebab kita pun ada 1 minit saja lagi. Kalau Prof nak wrap boleh
Okay, alright. Saya nampak ada satu lagi soalan, but I think probably that question can be asked to the presenters outside the session, since we only have 1 more minute to go. So I think I'll just use the time to wrap up the session. So I would like to thank again Dr. Atika, Prof. Azima, and also Dr. Tuti for the excellent presentation. It's very, it's a rare opportunity for us to learn about the rare conditions like this. And congratulations to the collaboration between Department of Psychiatry and also Department of Family of Medicine for the management of this condition. And also congratulations to Dr. Tuti and her for having this condition submitted. And I heard that the manuscript is in the review process now. Right. Thank to the organizer, Cik Buhari and team, as well as thank you for all the audience. Have a good day.
Thank you, everyone.
Thank you.
Assalamualaikum.
Waalaikumsalam. Terima kasih Prof.
Okay.
Untuk doktor kena scan dua-dua Untuk doktor kena scan dua-dua. Untuk staff hanya perlu scan yang atas saja, yang borang maklum balas. Terima kasih. Link tu sama Link yang saya share tu sama dengan borang maklum balas tu. Terima kasih.